Early on, we noticed that the Darzalex as monotherapy was very active as a single agent. And also in preclinical models, we had data that suggested or that demonstrated that when you add Darzalex to other backbone regimens that include either Velcade or Revlimid, that there would be, at least in these preclinical models, a synergistic anti-myeloma effect. So that was the rationale for moving beyond the monotherapy in very refractory patients to moving it up in earlier stage disease in patients who had received at least one prior regimen in combination with the standard type of backbone regimens, either a Velcade-based regimen or a Revlimid-based regimen. So that came about because we were looking to establish Daratumumab or Darzalex as a standard of care in relapsed myeloma. And we recognized that one of the standard of cares for relapsed disease is the combination of bortezomib and dexamethasone. And then in consultation with regulatory authorities, we reached an agreement which they endorsed on the design of the trial, which would be a standard of care for relapsed myeloma, namely bortezomib dexamethasone, plus or minus Daratumumab. So many of these patients had come on the study having already received treatments that included other types of active agents in myeloma, like Revlimid, like Velcade as well. And for many of these patients, even though they had a good response to the frontline therapy, nearly all of them will eventually relapse. And so the majority of these patients that are coming on this study have received at least one or two or three prior lines of therapy. And this is a desire to really establish a very effective regimen for relapsed myeloma and to build upon some of the active regimens that are already being used, either bortezomib dexamethasone, lenalidomide dexamethasone, and demonstrating how adding, in this case, Darzalex to either one of those type of regimens would improve the outcomes for these patients. And in the CASTOR study, we obviously added it to a bortezomib dexamethasone backbone. And in the POLLUX study, which, as you know, will soon be reported next week, actually, at the EHA meeting, we have demonstrated the benefit of adding Darzalex to the lenalidomide dexamethasone backbone. So for us, I think the striking aspects of the study is, one, the magnitude of the benefit. When we look at other relapse studies in terms of the hazard ratio, which basically translates into the risk of progressing on the assigned treatment arm, we see a very large magnitude of benefit here, a 61% reduction, which translates into the hazard ratio of 0.39. So a 61% reduction in the risk of progressing or dying if you happen to have been chosen or selected for the Daratumumab containing regimen. And to us, when we look across other studies, that magnitude of benefit is quite striking, and to use the words of Dr. Palumbo, unprecedented. The second aspect is, for the first time, we're seeing that the addition of a new mechanism of action, namely a monoclonal antibody, is having a significant immunomodulatory effect in being able to double the proportion of patients who get into a deep remission. When we mean deep remission, we're talking about being able to achieve a complete response. That, in the past, has been a very rare occurrence for patients with relapsed myeloma, and now we're able to actually double the proportion of patients who achieve a complete response. And also, when we look at the most sensitive ways of detecting disease through assays that are called minimal residual disease assays, we're able to show on this study that the patients who received the Daratumumab had a 5-time higher incidence of reaching what we call a minimal residual disease negative status, meaning that by the conventional assays that are very sensitive, we cannot detect any evidence of myeloma in their blood, in their bone marrow. So that happened, that is a very clinically significant event. To be able to achieve eradication of disease in a much higher proportion of patients with the combination of daratumumab is a very important, clinically significant benefit, and hopefully will translate into also significant long-term outcomes down the line in terms of improved survival. Yes, so in general, when we look across the adverse events, the numbers were pretty balanced. There was some higher incidence of thrombocytopenia, which is low platelets. But again, when you look at the clinical sequelae of that in terms of bleeding, we don't see a difference in terms of the incidence of bleeding between the two treatment groups. Most of the other side effects are pretty well balanced. The one that's not, and as expected, would be the incidence of infusion reactions from the infusion of Darzalex, a monoclonal antibody. And that's seen in a large proportion of patients, usually mild to moderate in severity. Only in 2 cases did it have to result in treatment discontinuation. And almost all of it is seen in the first infusion. So we use some pre-medications to manage that infusion, and then if you get through that first infusion, we almost never see it in the subsequent infusions. So the next step is to wait for the outcome of our ongoing frontline trials. There we hope to see the greatest benefit of adding Darzalex to other regimens that are commonly used in the frontline setting, like Revlimid, dexamethasone, like a bortezomib, a melphalan prednisone regimen, and then for the patients who are eligible for transplant, we have a phase 3 trial ongoing in collaboration with European cooperative groups, the IFM in France and HOVON in the Netherlands. And so that will take care of both, or that will address the potential benefit of Darzalex in both the transplant eligible patients who are being treated on that particular cooperative group study, as well as the 2 studies, frontline studies, one with a Revlimid-based backbone, one with a Velcade-based backbone for the transplant ineligible patients. The take-home message is that for the first time we're seeing what a new mechanism of action can do in terms of improving outcomes for patients with relapsed myeloma. And Daratumumab is clearly bringing a very meaningful and a strong clinical benefit. And our hope is that that benefit will even be enhanced and even be greater magnitude when we eventually get to the results of the frontline studies for newly diagnosed patients.